We can start the second part of our symposium. It's really easy for me to introduce Roger WEISS. Why? Because Roger WEISS doesn't need a presentation. It's a magister for all of us, a colleague, but also a magister, especially in the study of craving and the behavioral covariates of craving and psychopathology, the craving as psychopathology in the treatment of addiction. Roger WEISS is a professor of psychiatry at Harvard University and director of a very big research group at McLean Hospital. Please, Roger, the floor is yours.
Thank you so much. It's really a great pleasure and an honor to be invited to speak at this terrific conference. And today I'm going to be talking about improving outcomes with buprenorphine, the roles of behavioral therapy and early response to treatment. So what I'm going to be talking about today, some background on clinical trials with buprenorphine, then asking whether adding behavioral therapy to buprenorphine plus medical management improves outcomes. How should we measure successful outcomes for this population? And what can we learn from the early response to buprenorphine treatment that might improve outcomes? So I'm going to be highlighting research that was really headed by three people within my research group. Dr. Alan Bailey on the left, Dr. Kate McHugh in the center, and Dr. Victoria or Tori Votaw, all extraordinarily talented young people. So just starting out, how successful is buprenorphine treatment for opioid use disorder? So when it's compared to no buprenorphine or placebo buprenorphine, it's extraordinarily successful. The prescription opioid addiction treatment study, which I was fortunate enough to lead, we had 49% of people who, while they were on buprenorphine, had successful treatment outcomes compared to between 7 and 9% of people after they came off of buprenorphine. In the study of injectable buprenorphine sublocade or Buvidal, 29% of people on the injectable buprenorphine had successful outcomes compared to 2% on placebo buprenorphine. So if you look at buprenorphine versus no buprenorphine or placebo, extraordinarily successful. However, 49%, 29%, there's a lot of room for improvement for each of these. And so one of the obvious questions would be, well, would adding behavioral therapy to buprenorphine and medical management improve outcomes? Unfortunately, 4 major studies that looked at this all showed that adding behavioral therapy did not improve outcomes, and outcomes as measured by opioid use. But one of the questions in looking at them is, what about other outcomes besides just opioid use? And so Kate McHugh and the rest of us in our group had a study supported by the National Institute on Drug Abuse in the United States in which we were harmonized data from 4 clinical trials of buprenorphine plus medical management versus buprenorphine plus medical management plus some sort of adjunctive behavioral therapy, a variety of different ones: cognitive behavioral therapy, opioid drug counseling, contingency management. These were 4 studies, none of which showed an effect for behavioral therapy, and they were harmonized, and so the total number of participants for these 4 studies was 869. So our research questions was, does behavioral therapy, when you put all of these together, improve opioid use outcomes as measured by the number of opioid-free weeks? Does behavioral therapy improve treatment retention as opposed to the number of weeks remaining in treatment, buprenorphine treatment? Does behavioral therapy improve functioning as measured by the Addiction Severity Index? And are there subgroups of patients who respond better to additional behavioral therapy? And finally, are there moderating characteristics that influence the answer to any of these 4 questions, including heroin use versus prescription opioid use, additional cocaine use, the number of prior treatment episodes, age, presence of chronic pain, depression, PTSD. So the results, overall, behavioral therapy was not associated with weeks of illicit opioid use, treatment retention, or overall functioning. And if you look at the details of the numbers, the behavioral therapy group had a mean of 7.2 out of 12 opioid-free weeks versus 7.0, basically no difference. The behavioral therapy group versus those without behavioral therapy had 10.2, 10.3 weeks of retention out of 12. There was little change on the Addiction Severity Index measures of functioning at 12 weeks. And the effect of behavioral treatment on opioid use, retention, or functioning was not moderated by any of these characteristics that we looked at, with one exception, which is that having PTSD did show a trend towards significance for opioid use. Behavioral therapy was associated with a 2.3-fold increase in opioid-free weeks if you had PTSD. So in other words, if you had PTSD plus opioid use disorder and you got behavioral therapy, you were more likely to do well than if you didn't get behavioral therapy. There are a number of limitations on and caveats on these findings, though. One is that the study medical management, which I actually prefer to call medical counseling instead of medical management, because medical management as practiced in these studies was good counseling. It was just brief, and it was done by the person doing the prescribing, but it was counseling. The visits were more frequent and intensive than a community standard, and they were done by top quality addiction specialists. It's different from just community treatment. A study in the US showed that 74% of people in a community treatment setting received less than 1 day a month of psychosocial treatment, and that low-intensity psychosocial treatment, anything more than 1 day a month, outperformed less than 1 day a month. So the idea of no psychosocial treatment versus just a little, adding a little made a difference. Our studies were conducted prior to the fentanyl era and also prior to injectable buprenorphine. So some of the raw numbers in terms of level of success may be affected, and the role of behavioral therapy may be affected that may be different now. A big issue is that the results for buprenorphine plus medical management were really good. And so it left relatively little room for improvement. 10 out of 12 weeks retained. It's going to be pretty hard to do better than that by adding behavioral therapy. 7 out of 12 opioid-free weeks. That's not easy to do much better than that. The other thing is that clinical trials include a huge amount of support, social support not typically present in treatment settings. You've got research assistants who will go to the end of the earth to find patients who disappear, et cetera. So as we've done this, one of the things that we started thinking about is how success has been measured in buprenorphine trials. And it's typically, in all of these trials, it was measured by the percent or number of opioid-abstinent weeks. So in order to be classified as having an opioid-abstinent week, you have to show up, say that you didn't use opioids that week, and have a negative urine test. If you don't show up, it is typically interpreted as a non-abstinent week. So there's pros and cons of measuring weeks versus days of use. Measuring weeks a major advantage is that it helps simplify dealing with missing data. So if someone disappears in a 12-week trial after 6 weeks, and you're measuring days, how many days are you supposed to say the person used over the next 6 weeks? You're just completely making it up. If you say that you thought that they were not abstinent in those weeks, it's more likely than not that that's true. You know that that's not always going to be the case, but at least you have more confidence in calling it a non-abstinent week than trying to guess a number of days. One problem with the weeks issue, though, is that a non-abstinent week does not distinguish between whether you used 1 day that week or 7. You just didn't use that week. I'm sorry, you used that week. So, OUD research has typically focused on abstinence or near abstinence to denote treatment success, whether it's and examples, for example, it could be the number of abstinent weeks in a row or over a particular time period. So for the prescription opioid addiction treatment study, success meant that in at least 3 of the last 4 weeks of the study, you were abstinent, including the last week, and a missing week was considered non-abstinent. Other studies have had similar sorts of definitions. By that measure, 43% of the patients in these 4 studies combined achieved success. What if we looked at days of use for patients whose data were not missing so that we actually know what's going on? So this was a study that was led by Alan Bailey, the person on the left in those pictures. So using these 4 harmonized data sets, we examined reduction in the days of use for people still receiving buprenorphine and attending study visits. And we compared people who would have been classified as a success versus non-success. And this is what we found. If you look at the horizontal axis, that's the number of weeks in the trial, and the vertical axis is number of opioid days per week. The blue are people that were considered successes, and the red is people who were considered not successful. And what you see is that the people who were considered successes go from, everybody starts at 6 to 7 days a week on the left side of the screen. And the blue, the people who were successful, dropped to just about 0. But the people who were, quote, not successful, dropped to 1.5 days of use a week. And they're, quote, not successful. Now, about 25% of the people, you can look at the percentage of people who are still in the study down on the bottom of the screen. So by the end, 1/4 of the people are missing. So those people would have been, by definition, considered not successful. And 1/4 of the people who were not successful because they were not abstinent. But clearly, patients in the 4 studies reported a reduction overall from 6.2 to 0.5 weeks, but the non-successful people dropped to 1.5. So remember, these are people who are still on buprenorphine. So it really demonstrates the importance of retention in treatment. If you stay on buprenorphine, the likelihood is you're either going to do very well or extraordinarily well. Some people obviously weren't doing well, but this very large number of patients who were, quote, not successful were pretty successful. So now, still digging into these data sets, we were interested in the question of whether early response to buprenorphine predicted later treatment outcome. So as background and rationale, some medications, such as antidepressants, may take weeks to work optimally, so therefore waiting several weeks to examine treatment response may be helpful. If someone doesn't respond right away, you'd say, well, let's wait. This takes time. But what about the typical time course of response to buprenorphine to treating opioid use disorder? Knowing this could help guide clinical practice. If we knew early on that someone was heading for a poor outcome, maybe we could do something to intervene early on to help avert that. So as part of the prescription opioid addiction treatment study, we found that opioid use in the first week predicted an 80% likelihood that people would be using in weeks 9 through 12. And opioid use in weeks 1 and 2 predicted a 94% likelihood that they would be using in weeks 9 to 12. So clearly, using early on was a bad prognostic sign. Opioid abstinence in the first 2 weeks predicted 56% of non-use, 44% use. So bad things can happen if you get off to a good start, but if you got off to a bad start, the likelihood that good things were going to happen was not very high. Sean Luo at Columbia University harmonized data from our study and 2 other large OUD studies. Rather than looking at success and non-success, he looked at clearly bad outcome, 4 consecutive weeks of use. And he found that the first 3 weeks of buprenorphine treatment were critical predictors of relapse. If you had a negative urine test in the first 3 weeks, the likelihood that you were going to relapse by week 12 was only 13%. If you had positive or missing urines in weeks 1 through 3, it was 85%. So early response is very important. But what these, again, this is weeks. We were interested in days. How many days of use at the beginning actually make a difference? And so that's the next study that we've been doing. So we harmonized data from just 2 of these studies because not all of the studies had all the right outcome measures that we were looking at. And we were interested in how many days of opioid use in the first 3 weeks best predicted the likelihood of relapse to 4 straight weeks of use. So 52% of those with any use in weeks 1 or 2, 1 day will do, relapsed, compared to only 14% of people who didn't use at all. So just 1 day of use predicted a 3-fold or more difference. 61% of people with 2 or more days in the first 3 weeks combined relapse versus 17% with 0 or 1. Similar results for retention and number of opioid-free weeks. So what that means is even 1 day of use in the first 2 weeks was the best cut point to predict outcome. Really, we were looking for the best combination of sensitivity and specificity. 1 day was a trigger, in the first 2 weeks, was a trigger, bad things are coming. However, if you got to the 3rd week and you still had only used 1 day, now your risk is low. So 1 day in the first 2 weeks gives you a chance before week 3. If you can hold it at 1 day, you go from the high risk to the low risk. So it doesn't take much to tilt you in one direction or the other, but you have a chance, perhaps, to do something, some early intervention in those first 2 weeks that says, for someone that had only used 1 day, to say, time to nip this in the bud, time to really, 1 more day of use and you go into a completely different category. So in conclusions of all of this, many patients respond well to buprenorphine plus medical counseling, which I'd prefer to call it, as opposed to medical management. Even those who don't achieve abstinence often reduce their opioid use substantially as long as they stay on buprenorphine, emphasizing the importance of retention in buprenorphine treatment. The beginning of treatment can be a critical time in setting the tone for future treatment response. Intervention for those who use opioids early may prevent future heavy use. Merci beaucoup.
Merci beaucoup d'avoir respecté le timing et pour la qualité de la présentation. Alors, nous avons la chance d'accueillir Marc POTENZA, qui est professeur de psychiatrie à Yale University et qui, avant de nous présenter la présentation de ce jour, je tiens à le féliciter au nom du Congrès et de la World Association of Dual Disorder pour le prix qu'il a reçu, qui est le Pedro Ruiz Award, et vraiment toutes nos félicitations, Marc.
So I'd like to thank the organizers for having me here to speak on the topic of problematic use of the internet. I have a series of disclosures with respect to pharmaceutical and other entities. And if we think about digital technologies, they brought many benefits to people and societies, but there are also concerns that have been raised internationally, particularly for developing youth. And so groups like the American Academy of Pediatrics have generated guidelines, often based on limited data, to try to protect developing youth and to provide advisory about how much screen time should be introduced and how it should be introduced at different developmental stages. So Martin Paulus and a group of colleagues, myself included, reviewed some of the data about screen media activity in youth with a focus on mental health correlates as well as the neuroscience findings. And in this article, we adopted a Bronfenbrenner model to think about the complexities going from the very person-centered basic characteristics through societal levels, and over time, because events like the COVID-19 pandemic have impacted the ways in which people interact with screen media. So in order to test these models, data are important. One important data set in the United States is the Adolescent Brain Cognitive Development Study, which is a longitudinal study occurring over, proposed over at least a 10-year period, starting with children at ages 9 to 10. And over 11,000 youth were recruited with brain imaging measures every 2 years and behavioral self-report measures every year. And so we applied a machine learning approach looking at screen media activity, and a two-factor model best fit the data, where a little over a quarter fell into a high-frequency screen media activity group, and close to 3/4 into a low-frequency group. And the types of screen media consumed by the 9 to 10-year-old children were not uniform across the different domains. It was largely video-centric, where people viewed videos or played video games, with less socio-communication-centric activity. But importantly, this high-frequency group showed significant differences with respect to neurocognitive performance, behavioral problems, and measures of impulsivity and related constructs. That can be seen here with respect to neurocognition. This orange-red color is the high-frequency group, the blue color the low-frequency group, and we can see that the high-frequency group at ages 9 to 10, and this pattern persisted over a several-year period, showed higher levels of impulsivity, higher levels of behavioral activation, and lower levels of IQ, both crystallized and fluid intelligence, as well as lower reading scores, lower vocabulary scores, lower working memory scores. And this is by ages 9 to 10. Importantly, from a mental health perspective, the high-frequency screen media activity group scored higher on a broad range of measures of psychopathology, particularly externalizing concerns like oppositional and conduct-related concerns, as well as ADHD. So as youth develop, there are both behavioral and brain changes that occur, particularly during adolescence, where people like B.J. Casey have proposed that subcortical brain regions involved in motivational drive mature more rapidly than cortical brain regions involved in controlling those drives. That leads to adolescence being a time of increased risk-taking. Now, in the United States, as in many parts of the world, teenagers have access to smartphones. And a recent Pew Research study indicated that 95% of US teenagers aged 13 to 17 years have a smartphone. More importantly, I think, is that the proportion of youth who are saying that they are online almost constantly has almost doubled in less than a 10-year period, going from 24% in 2014 to 2015 to 46% in 2022 and 2023. And if we look at the degree to which this high-frequency screen media activity pattern replicated in an independent data set, we used the Human Connectome Project development data set, which was a cross-sectional study going from ages 5 to 21. And if we divided the group into the 5 to 12-year-olds versus the 13 to 21-year-olds, we saw a replication in the 5 to 12-year-olds, but in the 13 to 21-year-olds, we saw a different pattern, which was a high-frequency group defined more by socio-communication-centric screen media activity, like texting and chatting and use of social media. And if we think about the ways in which youth use social media, this has changed over the past decade. We can see that, for example, the use of Facebook has dropped. Facebook is now seen as an older individual's social media. And new forms of social media like TikTok have captured a large group of teenagers. And if we look at the group of individuals by the platform who report being online almost constantly, TikTok has the highest capture rate of 17% of the 58% reporting being online almost constantly. We also see that there are individual differences, and here we're looking at differences between boys and girls, and we see that for the social media platforms, girls more frequently report being online almost constantly as compared to boys, with the biggest difference being for TikTok. And these data resonate with what we see in a meta-analysis of largely adults, where we looked at internet gaming disorder, internet addiction, and social media addiction, where internet gaming disorder was largely male predominant, social media addiction largely female predominant, and internet addiction falling between the two. Now, one of the benefits of the ABCD study is that it's a longitudinal study, so that we can look at temporal relationships. And in this study, we looked at online social activity and relationships with ADHD concerns. We used random intercept cross-lag panel models, and what we found was that as the youth matured from late childhood into early adolescence, there was a directional relationship between online social activity leading to subsequent ADHD concerns, but not vice versa. And these data resonate with proposals by Jonathan Haidt and others that perhaps online activity leads to attention fragmentation. Now, looking at the sex differences, these findings were largely driven by the effects in girls, but not boys. Now, there are other concerns that are relevant to boys. This is a study out of Korea, where we looked longitudinally 1 year at-risk problematic internet use. And what we found was that at baseline, about 15% met criteria for at-risk, high-risk, problematic internet use. But going from baseline to the 1 year follow-up, 85% of that group remitted, but a new 12% emerged with at-risk, high-risk problematic use of the internet. So these concerns, while the prevalence estimates may be the same from year to year, the specific individuals affected may be changing. So we were interested in the factors that were linked to transitions, and what we found was that features of ADHD and gaming were linked to either the emergence or remittance of symptoms. Now, these and other data have led governmental groups in the United States, the US Surgeon General, put out an advisory on the relationship between social media use and youth mental health. He further wrote an opinion piece that social media platforms should be regulated to have product warning labels the way that alcohol and tobacco products do. And if we think about how the nomenclature systems that are utilized, like the 11th revision of the International Classification of Diseases, consider problematic use of the internet or behavioral addictions more broadly, a new category in the ICD-11 is the disorders due to addictive behaviors, and it includes both gambling and gaming disorders. There are hazardous entities which are akin to the hazardous or harmful alcohol use, which should be very helpful from public health perspectives. And then compulsive sexual behavior disorder, which may include problematic use of pornography, has been included as a new diagnosis, but as an impulse control disorder. So if we think about some of the data that were driving this from a neurobiological perspective, it has been found that across substance use and gambling disorders in a meta-analysis by Marciulichin and colleagues, that individuals during the processing of monetary rewards show blunted ventral striatal activation, which fits with a reward deficiency model, and appears to be also relevant to individuals with internet gaming disorder. But there's a wider range of activities that are performed on the internet, including social media and shopping and buying behaviors. And a group of us has proposed that the designation of other specified disorders due to addictive behaviors, which is a new diagnostic entity in the ICD-11, can be used to diagnose clinically these concerns. There also have been instruments developed and validated like the ATHS-2025, the Assessment of Criteria for Specific Internet Use Disorders, which assesses for the core ICD-11 criteria, the impaired control over engagement, increasing priority given to the behavior, and continuation or escalation despite adverse consequences, as well as major impairment and psychological distress. So this instrument assesses those criteria for online gambling, gaming, pornography use, social media use, and shopping and buying behaviors. As part of a European Union cost initiative, we've generated a free e-booklet that has been translated into about 6 languages. It can be downloaded for free at this website. And this e-booklet covers a wider range of problematic usage of the internet, including topics like cyberchondria and cyberbullying. Now, if we take a step back and think from a societal level, I think that Swanton and colleagues describe an important component where different jurisdictions must contend with how best to balance individual civil liberties with societal responsibilities and institutional duties of care to protect the public health. And in this process, there are multiple relevant stakeholders that include individuals who decide how to utilize the digital technologies, families, especially parents, who can provide guidance to developing youth, community groups, including teachers, as well as treatment providers who often feel ill prepared to help people with different types of problematic usage of the internet. Then researchers can gather information and provide information to the government who can think about how best to regulate and protect individuals. But there's also an important part for the industry with respect to transparency and access to data that could be useful in terms of promoting the public health. So in this setting, a group of us are participating in a Lancet Psychiatry Commission report on problematic usage of the internet. An initial description has been provided earlier this year, and we hope to have this published within the next 6 months or so. In the meantime, we have generated a review of current understandings of concerns related to behavioral addictions and how best to intervene, treat individuals with these concerns. And so, in summary, the internet has changed many ways of how we engage in the world. The internet and digital technologies have brought many advances that we want to continue to utilize, including with rapidly developing areas like artificial intelligence. But we also have to be mindful of how best we can help people who develop problems, and particularly how we can protect vulnerable individuals like developing youth to grow into their optimal selves. So I'd like to thank a large number of individuals, funding agencies, and thank you for your attention.
Thank you. And now, a good problem, the problem of the treatment, opioid agonist treatment during the war. We have some example, in this case, the example of Croatia during the war in ex-Yugoslavia, the example in Crimea, in which we spent 5 years to organize methadone and buprénorphine treatment, and when Russia invaded Ukraine, they stopped completely treatment and arrested doctors involved in the treatment. So I think this is a really problematic, especially in our times. The next speaker is Gavin Bart. No. Ramzy HADDAD from Beirut. And I think that also in the area of Beirut, the situation is not so calm. Thank you very much for coming.
Pour l'invitation, et je remercie aussi les organisateurs d'avoir accueilli le TDO7 au sein de la THS. Comme ça a été dit hier, le TDO7 devait se tenir à Beyrouth, au Liban, mais bon, vu la situation, ça a été annulé. Et donc justement, c'est ce que je vais un peu parler de ces conflits, et spécifiquement des traitements agonistes, opioïdes, dans ces régions à grand conflit. Mes slides sont en anglais, mais je vais parler en français. Donc, 3 régions que je vais évoquer, l'Ukraine, la Palestine et le Liban. Comme vous allez voir, il y a des défis communs et des ressources communes et des réponses qui ont été communes sans vraiment se concerter, en fait, et bon, proposer quelques pistes de réflexion. Bon, ces 3 régions ne sont pas les seules qui sont en situation de conflit actuellement, mais ce sont 3 régions actuellement où les TAO existent et qui ont donc évidemment été affectées par le conflit. De même, il y a eu, pendant la période de la Covid, il y a eu des accès aux soins qui ont été difficiles dans plusieurs régions du monde, mais ce n'est absolument pas comparable par rapport à ce qui s'est passé dans ces 3 régions, que ce soit en termes d'ampleur ou en termes de durée. Donc, vous connaissez tous ce qui se passe en Ukraine. Juste un rappel qu'il y a eu 2 phases. Donc, la première, février 2014, l'invasion de la Crimée et la guerre du Donbass. et février 2002, qui est toujours actuel, l'invasion à grande échelle avec, bon, au début, ça c'est au début, l'annexion de ces 4 régions à l'est de l'Ukraine. Avant, disons avant la crise, l'Ukraine est un des pays où l'épidémie de HIV est la plus prévalente. Il y a un très grand nombre de personnes qui injectent des substances, notamment des opioïdes, et c'est le programme de TAO le plus large d'Europe de l'Est et d'Asie centrale. Donc, ils ont la buprénorphine qui a été commencée en 2004, suivie par la méthadone en 2008. La majorité actuellement sont sous méthadone. Même avant la crise, les fonds étaient difficiles et c'était bon, souvent des fonds d'organisations externes, notamment Global Fund. Et bon, avant, c'était importé, la méthadone et la buprénorphine. Actuellement, il y a 2 régions en Ukraine qui les font. Avant 2014, les régulations des TAO étaient bon, inspirées de ce qui est fait à l'extérieur, mais modifiées selon un peu peut-être la culture ou les mentalités. Et comme vous voyez, ce n'est pas toujours vraiment evidence-based, dans le sens que les usagers devaient s'enregistrer dans le registre national des narcotiques. Ils devaient avoir avant échoué 2 fois des tentatives de traitement avant de pouvoir continuer un traitement de maintenance au TAO. Les take-home dosages étaient pratiquement impossibles. Les pharmacies avaient la possibilité de stocker juste pour 1 mois de médicaments et le transport entre les régions des médicaments était beaucoup plus cher que les médicaments eux-mêmes. Donc 2014, l'invasion de la Crimée, comme vous savez, la Russie interdit les TAO et donc ça a été interdit en Crimée. 11 programmes ont dû fermer, 10% des usagers sont décédés d'overdose, c'est-à-dire 80 à 100 personnes sont décédées, 20% ont pu aller autre part, recommencer un traitement ou bien faire des cures de détox, de sevrage, et la majorité a été perdue de vue. Il y a eu à ce moment-là une mobilisation assez grande des organisations internationales et locales pour essayer de trouver des solutions et aider ces personnes. Donc, suite à un peu ça, les choses ont été repensées. Donc, il y a eu en 2016 un changement dans les régulations, donc en permettant plus de take-home dosages, donc 10 jours, mais après 6 mois d'abstinence totale. Bon, la condition qui était un peu absurde d'échouer des détox avant de prendre a été enlevée. Et il y a eu plus de souplesse et de flexibilité dans les prescriptions, mais le fait de devoir enregistrer le nom au registre des narcotiques est resté, ce qui est souvent un obstacle pour les usagers et aussi une bureaucratie inutile. Et puis aussi, pendant cette période, il y a eu des cliniques privées. L'État a permis à des cliniques privées d'ouvrir avec une façon de faire qui est un peu particulière, donc qui était légale, qui n'était pas illégale, mais de façon à contourner un peu les régulations. Les cliniques privées prescrivaient des détoxications à long terme, donc ce qui fait que la prescription et le fait de rapporter est beaucoup plus simple que pour ceux qui ont un traitement de maintenance. Donc, pour contourner ça, ils continuent à prendre, mais dans un scénario de détoxification à long terme. L'inconvénient de ces cliniques privées, c'est que le patient lui-même payait. Donc, c'est pour ça que la majorité des gens n'étaient pas dans les cliniques privées. Environ 20% des patients sous TAO allaient dans les cliniques privées. Donc, 2022, bon, les défis, évidemment, c'était comment continuer à traiter les patients existants, comment traiter les patients qui étaient déplacés de régions sous le feu des bombardements, et les nouveaux patients qui avaient besoin, et certains, parce qu'ils ne trouvaient plus les opiacés illégaux, donc avaient encore plus besoin de TAO. De plus, plusieurs cliniques privées ont dû fermer, bon, évidemment, et les transports des médicaments entre les régions devenaient de plus en plus difficiles. Donc à ce moment-là, il y a eu une mobilisation des ONG, du ministère, de la société civile surtout, pour essayer de réagir très vite à ça. Donc la réponse du gouvernement et des ONG, bon, il y a eu un changement assez rapide dans les policies, dans les régulations, donc de façon à permettre des take-home de 30 jours au lieu de 10, okay, ce qui facilite les choses pour les usagers, de permettre aux pharmacies de stocker plus de médicaments pour 3 mois au lieu d'1 mois, et de permettre à chaque, disons, localité d'être flexible dans les régulations. Bon, aussi, il faut souligner le travail des ONG, notamment Alliance for Public Health, qui a pu transporter les médicaments dans les régions, parfois cachés dans d'autres choses, avec d'autres médicaments pour les faire passer. Les cliniciens, la réponse des cliniciens était variable, même s'il y avait assez de TAO pour durer beaucoup de temps, en fait, mais certains cliniciens ont eu peur et ont diminué les doses des patients pour pouvoir tenir, pour que les stocks puissent durer. D'autres ont priorisé les patients existants. Donc, ils n'ont pas diminué les doses, mais ils n'ont pas mis de nouveaux patients. Ils n'ont pas accepté d'avoir de nouveaux patients. Les cliniques privées ont presque, ce qui est resté, à part ceux qui ont fermé, ceux qui est resté ont dû diminuer les doses de méthadone graduellement pour que les doses puissent tenir. Les patients, bien sûr, souvent n'arrivaient pas à accéder aux lieux de prescription. Certains harcelaient et attaquaient d'autres patients ou les cliniques pour leur voler leurs médicaments et pouvoir en prendre, et les ressources humaines devenaient de plus en plus difficiles. Les prescripteurs, les cliniciens, tout ça, des fois, devaient dormir à l'intérieur des cliniques pour pouvoir assurer. Donc, malgré tout ça, en fait, ce que les études ukrainiennes faites en Ukraine montrent, que la réponse a été quand même positive, que là, dans le sens que bon, les patients ont été bien sûr affectés, mais il y a eu relativement peu d'arrêts de traitement. Il n'y a pas eu d'augmentation de consommation de drogues illicites pendant ce état, et le nombre de patients sous TAO est revenu très vite à la normale. Et ça, c'est grâce aux efforts vraiment coordonnés de la société civile et du gouvernement. Donc pour la Palestine, on a beaucoup moins d'études que l'Ukraine. Donc il y a quelques chiffres qui viennent de certains documents. Donc vous connaissez, bon, les territoires palestiniens, c'est la bande de Gaza et la Cisjordanie. L'estimation, c'est qu'il y a à peu près 26 000 ce qu'on appelle les high risk drug users. Beaucoup de gens injectent l'héroïne. À Gaza, la substance la plus commune est le tramadol, qui est un dérivé morphinique. En Cisjordanie, il y a beaucoup d'autres drogues, notamment l'héroïne. Et plusieurs centres sont présents dans ces régions, plus en Cisjordanie qu'à Gaza, pour traiter. Donc, la méthadone a été commencée en 2014, suivie de la buprénorphine en 2018. Elle est gratuite pour tout le monde. Et à la base, c'était beaucoup plus disponible en Cisjordanie que dans la bande de Gaza. Les take-home doses étaient possibles avec, disons, des critères un peu stricts. Bon, là, évidemment, l'interruption des traitements, surtout dans la bande de Gaza, pouvoir transporter les médicaments, avoir le médicament devient plus difficile. Et ça, c'est encore plus aggravé par tous les dommages psychologiques que les gens subissent, et le fait que les traitements agonistes ne sont absolument pas la priorité dans ce genre de situation. Malgré cela, les chiffres du ministère font qu'en Cisjordanie, en bande de Gaza, il n'y a aucun chiffre, en Cisjordanie, qu'ils n'ont pas eu à diminuer les doses, et qu'il y a eu des plans de, comment dire, contingency, différents pour essayer de maintenir tous les patients qui sont sous TAO. Au Liban, si vous allez au Liban maintenant, vous allez voir que c'est un pays magnifique, avec une vie de jour et de nuit qui est magnifique, mais bon, la réalité n'est pas aussi brillante. Depuis 2019, la pire crise économique qui a été décrite depuis le 19e siècle, une dévaluation de la livre libanaise à 98%, l'explosion du port en août 2020 qui a fait des dégâts considérables, et depuis 2023, l'extension du conflit israélo-palestinien, avec notamment beaucoup de pertes, mais beaucoup de déplacés aussi. Donc, avant la crise, on a au Liban juste la buprénorphine, on n'a pas la méthadone. Les gens paient leur traitement, qui était avant la crise de 200 € par mois environ, ce qui était déjà beaucoup. Donc, imaginez après la crise, qu'est-ce que c'est? Donc, 1200 personnes sous buprénorphine. Bon, les guidelines aussi ne sont pas toujours très intelligents, si on peut dire. Juste les psychiatres sont autorisés à prescrire. Les take-home doses sont possibles, 1 à 2 semaines maximum. Et à chaque prescription, il faut un test d'urine pour les opiacés. Bon, pourquoi? Bon, c'est les guidelines comme ça. Bon, s'il est positif ou négatif, ça ne change en rien, mais il faut le faire. Donc, 90% des gens sont traités par les ONG au Liban, donc ce qui compense un peu la défaillance de l'État. Donc, après 2019, les mêmes problèmes que j'ai déjà décrits pour l'Ukraine et le manque de ressources, le manque de médicaments, la difficulté à payer, à trouver les choses. Aussi, les ONG, le gouvernement se sont mobilisés. MENARA, qui est Middle East North Africa Harm Reduction Association, dont le siège est à Beyrouth, a beaucoup aidé pour amener des donations de médicaments, et donc et AFD, l'Agence France de développement aussi, pour payer le prix des médicaments qui devenait impossible. Donc, comme aussi en Ukraine, malgré tout, il n'y a pas eu d'augmentation significative de drogue illicite. La majorité des patients étaient retenus, mais malheureusement pas de nouveaux patients pendant plusieurs années. Donc, on peut dire dans ces 3 régions que finalement, ils se sont bien tirés, si je peux dire, par rapport au TAO, pas par rapport à autre chose. Donc, qu'est-ce qui explique cette résilience? C'est bon, ce travail de collaboration entre toutes les instances et surtout vraiment le dévouement de la société civile, des prescripteurs, de toute la société civile. Mais là, il y a une étude qui a été faite, l'équipe de Delamoura, qui pose 2 questions que je trouve très pertinentes, qui pour tenter d'expliquer un peu cette résilience. Donc la première question, est-ce que dans ces 3 régions, en fait, le fait avant la crise, de travailler dans des conditions qui sont à la base difficiles, avec peu de ressources, avec des difficultés, a fait que après la crise, les gens ont pu réagir de façon très vite et quand même assez efficace? Est-ce que c'est ça qui explique ou qui peut expliquer en grande partie la résilience? Et la deuxième question, quels seraient finalement les coûts à long terme de cette résilience pour les individus, mais aussi pour le système de santé? Donc il faut des études pour répondre à ça. Mais pour la première question, que je trouve assez pertinente, c'est vrai que dans ces 3 régions, il y avait beaucoup de difficultés avant. Okay. Dans les 3, il faut enregistrer, il faut une bureaucratie énorme, il y a des attentes, des listes d'attente énormes, des critères diagnostiques, pas diagnostiques, de régulation, bon, qui ne sont pas toujours très logiques, des ressources financières faibles, des ressources humaines faibles. Donc, c'est vrai que même si, comme dit Platon, la nécessité est la mère des inventions, le fait d'avoir travaillé longtemps, et je le sais du Liban, j'imagine que ça doit être la même chose en Ukraine et en Palestine, le fait d'avoir travaillé longtemps dans des conditions difficiles a fait que nous avons pu réagir de façon très rapide et quand même assez efficace. Mais aussi, bon, pour répondre à la deuxième question, improviser et la résilience, ce n'est pas du tout suffisant. Il faut vraiment changer les policies, il faut vraiment changer les régulations. Ce n'est pas juste suffisant de dire oui, on est résilient. Donc il y a ce document qu'on avait travaillé depuis plusieurs années sur les législations et régulations idéales par rapport au TAO et qui avait été coordonné par Olivier Simon. Et les recommandations clés étaient justement de ne pas avoir d'autorisation nécessaire préalable par le gouvernement d'enlever les barrières financières, d'avoir une coordination vraiment entre tous les intervenants et de diminuer autant que possible la stigmatisation. Et vous voyez qu'en fait, dans ces 3 régions que j'ai mentionnées, la plupart de ces recommandations clés ne sont pas malheureusement faites. L'Ukraine a beaucoup changé depuis, donc c'est en train. Au Liban, nous avons présenté un document au ministère de la Santé pour s'aligner autant que possible sur ces recommandations. En Palestine, je pense que c'est encore trop prématuré. Et aussi, la semaine passée, justement, je voyais ce document qui est sorti par WHO, qui est justement les TAO en temps de crise, et insister sur la continuité des TAO en temps de crise, sur la résilience de la communauté avec tous les partenaires. En temps de crise, augmenter les take-home doses, augmenter la possibilité de répondre au risque d'overdose qui peut être là, augmenter la possibilité d'aider les gens qui veulent se sevrer ou qui veulent faire un traitement de sevrage, et augmenter le support psychosocial. Donc on a fait un peu tout ça de façon spontanée lors des crises, mais ça reste un document important, et il y a certains collègues du TDO qui ont collaboré à ce document, notamment Marie-Ève Goyer et Idriss Abba. Donc, ce matin, Alexis Gouzdil a terminé sa présentation en citant Albert Camus. Je vais aussi terminer ma présentation en citant Albert Camus par cette belle phrase qui montre que l'être humain, dans les moments difficiles, arrive toujours à trouver en lui les ressources et la force nécessaire pour continuer à avancer. Au milieu de l'hiver, j'apprenais enfin qu'il y avait en moi un été invincible. Je vous remercie.
Merci beaucoup pour cette belle présentation. Donc, ça nous fait 3 présentations et 15 minutes justement pour pouvoir échanger avec les speakers, où on a vu un panel effectivement donc de thématiques évoquées. Est-ce qu'il y a une question dans l'assistance? Pas pour l'instant. Moi, j'en ai une.
Hello.
Ah.
Hi, my name is Jason Farrell. I'm from Amsterdam. My question is for Marc. I liked your presentation, but maybe I missed the beginning. You talked about behavioral therapy in combination with the medication. Yeah, him, sorry. Roger, sorry, Roger, yeah. What were the outcomes of that behavioral therapy? Was it behavioral intervention? What kind of behavioral therapy? Because you didn't really talk, you talked about abstinence as the marker for success, but what kind of outcomes were you looking for the behavioral therapy? And also, I liked what you said about any day a drug user doesn't use, that's a successful day in the eyes of treatment providers. So you had a lot more success than you actually could document, I guess. But I'm very concerned about the behavioral therapy or the intervention that you were providing. Can you talk about that?
So we looked at 4 different trials, and we were harmonizing data from them. 2 of them were by David Filene at Yale. In the first one, they had what they called standard medical management. The medical management was a 15 to 20-minute visit that was structured to talk about, obviously, medicine, side effects, et cetera, but also recommending that people attend mutual support groups, asking about craving and how people dealt with them. It was sort of brief counseling. So in the first study, he compared 20 different lengths of the same, of that intervention, and the longer ones dealt with interpersonal issues, family issues, et cetera. The second Filene study added cognitive behavioral therapy to the medical management, and people, half of them got it, half of them didn't. The Walter Ling study, people got either medical management alone, medical management plus cognitive behavioral therapy, contingency management, or both. And in the prescription opioid addiction study, It was opioid drug counseling, which was sort of standard relapse prevention drug counseling. The outcome measures in all of these was abstinent weeks in sort of slightly different, how many was considered successful or not. But that was really the reason that we looked more deeply at these definitions of success to look at days of use, and showed that abstinent weeks really misses something. And that combining that with days of use that showed dramatic decreases in days of use among people who were not, quote, successful, was an interesting finding, I thought.
Yeah. So no behavioral change markers were included? And the only behavioral change was abstinence?
In the analysis that Kate McHugh did, we looked at functioning as well. There were no differences in functioning based on that. Of course, the Addiction Severity Index is not a particularly good indicator of change over a 12-week period. Quality of life is something that we're looking at now to see whether there were changes in quality of life. That Dr. Bailey is looking at that as we speak.
Gabrielle, thank you.
Thank you. So thank you very much for your presentations. It was kind of a broad scope we got presented here. So I might start with Ramzy, with our last presenter. Yes, I agree. Lebanon is a beautiful country. It's very difficult to visit though, and you face a lot of problems. You were referring in your presentation of having a more liberal take-home doses. I refer to my experience in implementing a buprénorphine depot when Ukraine war started. So have you been thinking about using this kind of medication? And also referring to Roger of pointing out the non-failures, you know, that my understanding, the first week was very important. So maybe you could comment also on the dosing issue, because this seems to be very relevant, and especially in a difficult, unstable area, how to proceed with this kind of induction, the importance of the first week, and the possible continuation with the depot on for these countries. And finally, I wanted to ask Marc, referring to your first slide, you know, what would you recommend, since having the behavioral addiction in the substance use scenario of ICD-11 and having the comorbidities of ADHD, what would be your recommendation for school teachers, or when would you start on giving advice when to start and how much you use all the online tools? Thank you very much.
Thank you. When the crisis started, in fact, so buprénorphine, the stockage was very limited, so we had to decrease the doses for all patients. But then when we started having enough buprénorphine, sometimes what we were doing is increasing the dose, the take-home dose. And let's suppose that the patient is taking 12, we're giving 16, and also they can stock medication at home. Eventually, if there is another shortage or displace people or that kind of scenarios, but the main problem in Lebanon, besides the war, ADA, is the economic thing, is the price of ADA, which is not covered by any third party or the government or that kind of scenarios. In Ukraine, if I'm not mistaken, now it's subsidized by the government. No, it's covered, if I'm not mistaken.
First, we were working with donations.
Yeah.
I think the issue of early dosing is really important. If you look at all of the trials that were part of the study that I was talking about, were done in the in a period before fentanyl came to the United States, and so dosing was pretty straightforward. The target was 16 milligrams. Some people got a little less, some people got a little bit more, and typically they'd get to 16 milligrams in the second day. But it isn't, when you realize how important that first week is, getting the dose as high as possible, as quickly as possible is important. But right now, there's a lot of controversy about the best way to dose people who have been using fentanyl. Some people start with very low doses. Some people think you should start with high doses. There's more of a trend toward just giving injectable buprenorphine right off the bat. It will be interesting to see how that affects that first week or the first couple of weeks. People are afraid of potentially precipitating withdrawal with too high a dose of buprenorphine early on. But you raise a very important point, which is getting the dose right early on is very important, because that the early response is so important.
So thank you for the question. If I'm to understand it appropriately, the question is about when to intervene, and that question may depend on the different stakeholders, like in the Swanton et al. Study. I think educating parents and adults about internet use and the effects on developing youth is one way that can start, as soon as possible. As we get that better understanding, to provide that information to individuals. In terms of developmentally, when infants go to children to adolescence, I think trying to develop skills for things like emotional regulation and being able to tolerate delays in gratification are very important skills to develop early in life through early attachment processes. If we think about what's been empirically tested for interventions at a prevention level, I think Patricia Conrad's work is particularly noteworthy, where her intervention was based on looking at a broad range of measures and looking at which measures accounted for most of the variance in terms of predicting subsequent substance use going from childhood to adolescence. And there, things like emotional regulation, impulsivity were the factors that accounted for most of the variance. And so in her middle school, late middle school, like 7th, 8th grade intervention program, that's been empirically validated to blunt substance use problems in developing youth over a 5-year period, teaching individuals skills to regulate emotions, to delay gratification. Those processes are very helpful. I would imagine those are going to be helpful for screen media activity as well, because one of if one looks at the motivations for using screen media activity and those motivations that are most linked to problematic engagement, using the internet or digital devices to cope with negative emotional states is one of the most robust factors linked to problematic usage. We don't have all the data yet, but those would be my thoughts.
I have a comment for Dr. Potenza. My greatest anxiety has always been in academia that I'm going to stand on the podium and give a lecture, and somebody will raise his hand and said, "Excuse me, Dr. Kemener, have you read the last issue of the Mongolian Journal of Psychiatry that just came out yesterday that pretty much dispute everything you said?" So I have a present for you, Dr. Potenza. It's Scientific American from October, which I buy for my kids whenever I read it. And there's an article here by Laura Edelson. She's from Northeastern Boston, and it's called "What I Wish Parents Knew About Social Media." The problem that we have here is, like in translational research, we talk about theories and statistics and whatever. How do you teach parents to handle overuse of social media. And here's the first problem. Kids are much more competitive and knowledgeable than their parents. I'm an analog guy who lives in a digital world, and they're very impatient when they try to teach their parents to use their computer or the internet or something specific. So there was a joke about it that said that a girl told her mom, "Don't you forget I taught you how to use a computer." And mom responded, "Don't you forget I taught you how to use a spoon." So the first issue is how to improve level of communication. So two of the comments here are fantastic. I'll give it to you because I read it and I finished. First of all, your teen isn't the customer, your teen is a product. Because what kids don't understand, that all this information, whatever you do online, goes to somewhere, and this somewhere send it to other potential users who would exploit your kids. So this is really something kids becomes product. The second issue is the algorithm feeds are designed to maximize usage, not well-being. So we're dealing with the enemy. This is like big tobacco, big cannabis, big whatever, and we can come with whatever we want, but we almost need to do some kind of guerrilla war to teach parents how to start at a very early age. And I'll finish by telling you I've been on an airplane and flying 5-6 hours from the East Coast to the West Coast, and there was a little cute girl, maybe 3 years old, on these plastic computers playing nonstop, and I was watching her. So father gave me a look, you know, in the United States, everybody who looks at the kid is a potential pedophile. I said, "Is anything wrong?" And I said, "Your sweet girl has not stopped working on this computer for 3 hours." And he said, "What can I do? If I'll take it away, she will cry." So these instruments became electronic pacifiers.
We are very short in time. We'll leave the opportunity to Marc to answer or give a comment.
Yes, I agree that this is a very rapidly changing space, and there are different generational and even subgenerational differences in terms of understanding and comfort. I also agree that we need to do a better job at understanding the algorithms and how they may be influencing decision processes and perhaps subverting free will. To that effect, there was a documentary about 5 years ago called The Social Dilemma, which I would encourage people to watch if they haven't done so already. It's a bit outdated because it's in a pre-AI environment, or pre-AI being the way that it is right now. But it does speak to the point of a number of people from Silicon Valley companies leaving the industry because the approaches that were being taken by the company didn't sit well with their moral framework. And we have had whistleblowers like Francis Naughton come forward to testify against some companies. And this has led to different regulations in different jurisdictions, including in the EU, where large fines have been levied against Meta. So this is a process right now, and how best to equip all the different stakeholders to protect individuals and to use these digital technologies that have brought many benefits. How do we keep those benefits while protecting individuals is very important, and it's changing and changing rapidly.
Merci beaucoup pour la qualité des présentations, la qualité des speakers. Nous avons tous beaucoup de questions à leur poser. Nous aurons l'opportunité de pouvoir échanger plus tard dans la journée. Merci beaucoup. Nous allons donc clore cette section avec le professeur Maramani, et on vous donne bien entendu rendez-vous pour la suite qui se poursuit immédiatement. Donc ne quittez pas effectivement l'amphithéâtre. Merci.